Our next speaker is Dr. Neill Duncan. He will talk about patients with failed kidney transplant on hemodialysis/PD.
Thank you very much. Thank you so much for inviting me. It truly is an honor, and it's lovely to be here with the brains and thoughts that are going on this afternoon. I wanted to describe the scale of the problem. It's the fourth most common cause of end-stage renal failure, transplant failure. And in the US, this is from the US RDS, admittedly 10 years ago, 30,000 people were on dialysis with transplant failure. That's larger than the UK population on dialysis in its entirety. Then if we look at transplantation, as was mentioned by our pediatric colleagues, this is not for life. It might be that we wish it, but it isn't in reality for our patients. And the probabilities of return to dialysis or retransplantation within 10 years vary. They're higher if you have a deceased donor graft, so 33%, 1/3, and 25% if you have a live donor graft. So this is a reality for our patients. We've known for 20 years that we should be doing better. Now, this is an issue of measurement of process, perhaps, but this is a nice paper from Gill, which shows from healthcare financing administration forms that actually the achievement of hematocrit was as poor in people returning to dialysis as it was in people with native renal failure starting dialysis. One would argue they were in good pre-dialysis care. And this is another paper from a Spanish group in cross-section showing that actually we do poorly through all stages of transplant function, starting from CKD1T, so CKD stage 1 with a transplant, following through 2, 3, 4, and 5. We can see that the intact PTH levels are rising. We can see that our mean systolic blood pressure control is modest at 150 millimeters of mercury. And we can see that actually the hemoglobins achieved are not very good and certainly tail on mean from CKD4 through 5. So we need to take preemptive action. Why is this difficult? It's extremely complicated. And I don't know how many clinicians sit in the audience who actually do this, but actually failing grafts are difficult emotionally. And I think it's important to say that from the outset. Patients are not willing to accept the failed graft. They don't like a special clinic that's called the failing transplant. They don't like being identified for special treatment within a normal clinic. And we also have a problem with it. So we tend to ignore the issue, or we focus upon things that are positive and not address the challenges. So this is a paradigm that I've adopted through advanced chronic kidney care in my program with my colleagues about shared decision making. So I've heavily emphasized we on this chart. Where are we going? How did we get here? So a narrative. With whom are we going to travel forward? Who is our primary carer? What is the next step in transition? What are we going to do with immune suppression? And I'll answer that perhaps a little bit by a review of the data shortly. How do we transition from CKD5T to dialysis or supportive care? Or more importantly, although it's not emphasized because it drops to the bottom, how do we retransplant you? And how do we manage ischemic heart disease? Not least for our assessment for retransplantation. Sometimes we're overly preclusive by screening, which means that we're holding people back from being listed. But actually in itself, given the fact that cardiovascular mortality is so prevalent. So I wanted to talk about patient survival. This is a very nice paper from Rao in the American Journal of Kidney Disease, 2007. So a little old, but in a substantial data set. And what it shows is the hazards ratio in the first year. This is the normal line. And you can see the hazards ratio is 14 within the first days to month and drops to 2 years by the first 3 months. But if you look beyond year 1 and on beyond year 5, the hazards ratio for death on dialysis with transplant failure are above normal. So it's a persistent risk. Gill identified that this is not just a risk of immune suppression. So this is a study of US RDS patients with follow-up of 15 months, showing that 21% of the cohort had died, of which a third were cardiovascular and about a sixth were infective. But when they looked at issues such as a rejection, which implies increased immune suppression, antibody induction, a maintenance of a tacrolimus or cyclosporin, none of these had an effect upon survival or death. So it isn't just about immune suppression and infection. Certainly comorbidity separates and stratifies our patients. So if you're a patient with no comorbidity, you have the better survival. If you have congestive cardiac failure, diabetes, and peripheral vascular disease, you can see each of those have an effect. And cumulatively, our patients have many. They have a complex pathway where many of these conditions are coexistent. When is the problem in regard to death? The problem is in the early stages, so within the first year. So you can see that diabetics are more prone to death on dialysis after graft failure than non-diabetics in this large study, again, from the USRDS. It's points of transition that are important. We have increased risks of death after transplantation or during waitlisting incrementally, but it's greatest in those returning to dialysis. This is an extremely vulnerable group. And if you look at the cause-specific mortality, then again, it's cardiac and it's sepsis, both in the diabetic and non-diabetic group, but no doubt diabetics are more prone. We were talking a little bit about patient focus in regard to outcomes. How will I live with transplant failure on dialysis? The answer from this study from Pearl in nephrology dialysis transplantation 10 years ago, based on DOPS, shows that actually you'll live with less physical function, less general health, less social function and vitality, and unfortunately, more depression. So if we're asking what trials or what studies we need to do, then this is a group we certainly need to look at from a patient outcome. So dialysis after transplant failure, when? As ever, these studies are very difficult. The ideal study was a randomized controlled trial, and it was difficult to know what was early and what was late. If you start early, based on GFR criterion, then your GFR is going to be lower for a given muscle mass, and so you're confounded by the issues of sarcopenia that we heard talked about, worse comorbidity and poor nutrition. If you start late, you have a higher muscle mass, and you have less comorbidity and good nutrition, and this compromises the outcomes of studies. It's very difficult. This is a nice review of transplant-naive patients returning to dialysis, and you can see from the forest plots that most of the time it looks as if it favors later start, but most of the time the error lines cross the neutral point, and the ideal study did one and the same. If you add in the transplant element, there are peculiar things with a transplant. Infection, which relates often to episodes of rejection and over-immune suppression, and urological complications, often with recurrent urinary tract infection, which really affect the outcomes in such studies. And the studies are really very few and far between and somewhat historic, and largely in the last 10 years from one author only. So again, timely dialysis, but what does this mean? It's a little bit, again, like Pontius Pilate, as Carmine was saying. I wash my hands. Timely dialysis, there's no absolute. Which type of dialysis? Well, we've talked a little bit about residual renal function, and we've talked about incremental dialysis, and we believe that residual renal function is incredibly important. It leads to better patient survival and probably better quality of life. And this is through better volume control, solute clearance, but also a less anti-inflammatory state and clearance perhaps of different types of middle molecules. There's also an argument that our treatments may be deleterious. Although we talk about frequent dialysis, it may be deleterious in this review on residual renal function. This study is nocturnal hemodialysis, and the nocturnal hemodialysis group in the FHN trials actually had a large degree of residual renal function, and they were harmed. They lost residual renal function through that study. So this is very complicated. How do we treat our patients? So if we look at big cohort studies, again, Pearl looked at the Canadian group to start with dialysis after graft loss, 1991 to 2005, and you can see that actually the Kaplan-Meier for both groups was the same. So this was an important paper because it means that actually home therapy with PD after transplant failure is a really viable option, okay? And then we need to take into the other equation the values of our patients, and many will want treatment at home. He went on then to study a larger data set in the US of 16,000 people. The numbers are evident. Unfortunately, the use of PD in the US is very clearly low versus HD, and PD patients tended to be younger and had fewer comorbidities, so we need to take that into account with adjustment. The survival for the entire period was equal in both groups. Interestingly, the temporal arrangement was telling us a little bit about the therapies. So the adjusted survival for the PD group was actually greater in the first year, but lower after 2 years. And that might be to do with residual renal function loss. It might also be to do with the effects of calcineurin inhibitor on the PD membrane. We can talk a little bit about that in a minute. Certainly they found that they could stratify perhaps patients who were going to do more poorly on PD, and those with very high body mass index or particularly low renal function. Now, I think trajectory of decline in renal function is important and interesting, and I think that there are analyses now that are helping us, so it's not just about delta GFR, but it's how did that GFR change. And I think before a point of transition, whether your GFR was gradually decreasing over many years or was stable and then went rapidly downward could be extremely interesting in regard to what happens when you dialyze somebody after graft failure, because it may predict how the residual renal function performs. So if we look at non-transplanted patients from a veteran study in the US of CKD stage 4 and subsequent outcome, they use something called latent class group modeling, which I have to say I'm not a statistician, but led to 3 classes, one of which was defined as the referent group, which was a slow decline of about 2.5 mils per minute per year. And then they had a class 2, which was a rapid declining group. And then they had a class 3, which was a stable group with decline and then much more rapid decline after year 1. They basically looked at a composite of kidney disease outcome and death. And what they showed was that the composite of kidney disease outcome at 1 year was increased in those that had fast decline or stability and then rapid decline. But there was a competing interest because those with stability and then rapid decline and more decline tended to die more quickly. So I think that we need to understand a little bit, not just about what we do. We might be a dialysis doctor. Our patient is a patient who carries kidney illness. They're not a dialysis patient. They're not a transplant patient. They're traveling a journey. So I think what we are or should be interested in is what's happened before the modality with which we treated someone. I hope that sort of point is made. So using computer analysis, we can actually start to stratify the trajectories of decline in renal function before dialysis start. So for example, this is bilinear with stability and then rapid decline. And then there are patients who have decline and then stability. And you can show that various patterns of trajectory predict death and the requirement of end-stage renal failure. And there are several recent papers that suggest that these analyses may be useful to us in regard to understanding what happens subsequent to graft loss and on dialysis. It would be interesting to study this. What about the effect of withdrawal of immune suppression? Certainly, we should consider the value of residual renal function, and reducing calcineurin inhibitors may increase your residual renal function, but we don't want to sensitize patients and stop them being transplanted. And certainly, we don't want to precipitate acute graft loss and nephrectomy, which is a further sensitizing event. There are absolute indications for nephrectomy, which are related to systemic inflammation, sepsis, or malignancy. When the US was surveyed as to what they did for people on dialysis after graft loss, most people did not have a protocolized approach to this, although most said that they'd taken their patients off by 1 year. So this is a group without immune suppression at 1 year, but for steroids. Steroids persist. And I think this is very important because subsequent analyses suggest that outcome from cardiovascular disease and sepsis in people on dialysis is worse in those that have persistent steroids. So I think as clinicians, we need to look at that practice. What about sensitization? This is quite an interesting study, which in the interest of time, I won't go into too deeply. But essentially what it shows is that at graft loss, there was a degree of donor-specific antibody. With nephrectomy, it increased. Certainly by day 5, it was very present, suggesting it was preformed and was mopped up by the presence of a kidney, which was no longer present. But there was an instance of de novo antibodies. So stopping immune suppression is something that is going to reduce our patient's matchability to a future graft. This is a widely reported study that relates 43 people who started dialysis with transplant failure versus those with native failure. The transplant group were generally more inflamed. A subgroup of the transplant group had nephrectomy by indication. They were generally sicker than those that did not have nephrectomy by indication. After their nephrectomy, their inflammatory markers and their hemoglobin responsiveness improved, whereas those who were not symptomatic but not nephrectomized remained in a poor status. So it's difficult, it's conflicting, and it's something that we need to look at further. PD outcomes after transplant failure. I think there's various myths that this is dangerous. Sepsis, inadequate dialysis. This is not true. So if we look at this study, it essentially compared patients with transplant failure with those that were new to dialysis and transferred from HD, and survival and technique survival were equal in both groups. And we can see that there was a fair proportion of people on APD, but also on CAPD, which was probably an appropriate treatment for people with adequate membrane transport. And then a larger study from Australia and New Zealand, which essentially showed that PD starts after transplant failure were prejudicial. They tend to be in a younger group or Caucasian group. There was a prevalence in New Zealand over Australia, and they tended to be fitter. PD with transplant failure on multivariate analysis had comparable mortality to hemodialysis. Death-sensitive technique failure, once again, was equal. Peritonitis-free survival was equal. So people who are immune suppressed with grafts in situ don't get peritonitis recurrently. What about peritoneal dialysis after transplant failure and naive patients in meta-analyses? There are 12 studies in all. Only one study reported increased mortality, 11 showed equivalence. Only one study studied really membrane function and showed that there was no effect from calcineurin inhibitors on DP creatinine or ultrafiltration. And one study reported the relation of immune suppression with peritonitis, and once again, it was persistence of steroids that was the risk. In a pooled analysis of the group, and these are the forest plots, we can see that the meta-analysis of mortality showed that it neither favored one form or the other, and mortality risk and technique failure and peritonitis were equal. That was in comparison with people who'd had native failure. Finally, hemodialysis outcomes after transplant failure in the current era. Returning to hemodialysis after graft failure, this was a survival study with propensity matching, and essentially showed that central venous catheter use predicted mortality. Unfortunately, that's a marker of comorbidity. It's not necessarily the thing that's driving poor outcome. Effective treatment time and blood flow were important, whilst there was a univariate analysis suggesting higher mortality risk in transplant-naive patients, not transplanted patients. This was no longer sensitive after propensity matching. So there's a suggestion that in a modern era, transplant failure on dialysis may not be such a poor marker. And I think that things like propensity matching and bigger data studies are maybe re-educating us about the modern era. Certainly in Japan, where we see unusual associations, certainly they found cardiovascular death and infection death, but that actually the hazards ratio after transplant failure were low, and low for cardiovascular disease. I don't know how to report that irregularity. How do we look at metrics in the first year? Unfortunately, we don't do well. So we had this study by Gill showing that we weren't looking after people with transplant failure coming to dialysis. We don't get our targets so sharply in people who are on dialysis after transplant failure. Prevention of sepsis. The sepsis rate is highest in the first 6 months after transplant failure. And the risks for sepsis are aged, obesity, diabetes, peripheral vascular disease. People who had non-depleting antibodies for transplantation were at reduced risk. Certainly in the US, I know ATG is widely used. We use alemtuzumab in Europe and the UK. These are going to be issues for our patients in the long term. So I wanted to talk finally in the last couple of minutes, if you give me the kindness, about inflammation, cardiovascular disease, and transplant failure with dialysis. We've been very interested not in the immune suppressive elements, but what is the native state of the immunity in somebody who has a transplant in situ on dialysis. And we are looking at the interaction between dialysis, transplantation, and this innate immunity. We find that people have high monocyte counts, and we find that those monocyte counts actually correlate both with mortality, but also lipid profiles, so may be related to cardiovascular outcome. And we're very lucky to be looking at this work locally in the laboratory in terms of monocyte phenotype, and also in terms of numbers through Mondo and other large databases with Peter Katanko and the Research Institute, and we're grateful for that. If we look at monocyte lymphocyte ratio in peritoneal dialysis, it also correlates with outcome. So there's something about our innate immunity that makes us more at risk of cardiovascular disease and dyslipidemia. So this is something that we will look at going into the future. This is the data in the Mondo data set, which shows that there is a dose-related relationship of the monocyte to lymphocyte ratio throughout periods. So this is the acute phase in the first 6 months, and these are era afterwards into the long stable phase, and it correlates out and is also at a level that actually looks like other studies. I was very interested by phasic dynamics of inflammatory markers, which the Mondo group once again have shown, which show that essentially the neutrophil to lymphocyte ratio is high in the early phases when you start dialysis, then plateaus, and then rises in 6 months prior to death. So it'd be very interesting to see what's happening to the inflammatory process in the first 6 months of dialysis treatment, then through a plateau phase, but also in the 6 months antecedent to death, just to see if there's something that we can get in terms of a signal. The points that I wanted you to take away are that the transplant failure in dialysis group is a large in number. There are wide opportunities for improvement in care. We've revised our understanding of survival with transplant failure based on more current analyses with big data and propensity matching, suggesting perhaps the group is not doing as poorly as it has historically. I think a big message is peritoneal dialysis is a strong option after transplant failure. Residual renal function must be considered in the choice of dialysis modality and perhaps is better preserved in PD, but is also affected by the withdrawal of immune suppression. Depleting antibodies and prolonged steroids adversely affects sepsis rates on return to dialysis, and I think that's well worth studying. And maybe there's an opportunity in Apollo and other databases. And quantitative and qualitative changes in innate immunity are important and are understudied by our group. I wanted to thank very much Peter, but I think we'd all agree that personally his arrangements around the Renal Research Institute and this symposium particularly just illustrate what a magnanimous and great and generous intellect he has. Janice undoubtedly, and then my collaborators Damien Ashby, who has a statistical brain at Hammersmith, the Institute of Global Health Innovation, and Fred Tam. Thank you very much.
Thank you very much, Neill, for this really interesting presentation. Very, very interesting. I remember very well the discussions we had on rounding dialysis clinic. Oh, should we stop immunosuppression? Or yes or no? And there is some data that give us now more guidance than certainly in the days when I was still practicing. Is there actually a difference between patients who received cadaveric transplants versus transplants from live donors?
Centers might differ in the way in which they approach induction immune therapy. I doubt that they differ in regard to chronic maintenance therapy. We know that biologically the situation is perhaps less inflammatory in the long term following a live donor than a deceased. That has to be borne out by the fact that the graft lasts longer. I'm not aware of any data in regard to return to dialysis related to live versus deceased donor. But what we know is that the risk of return to dialysis is much greater. Yeah. So,
Okay.
Best I can answer that.
Thank you, Neill. Question here, is the first-year mortality rate different between those who start dialysis after transplant failure versus no previous transplant?
Sorry, say the question again.
Is the first-year mortality rate different between those who start dialysis after transplant failure versus those without a previous transplant? So,
well, the Kaplan-Meier and the data would suggest that, yes, definitely. Yeah. Although in the recent eras, with our ability to use a bigger data sets, I think our power is better, our sensitivity is probably better, and our adjustment for the differences is better. So I think, yes, the effect still persists. It's a risk for mortality.
If I may ask you a follow-up question. What you mentioned that the trajectories of transplant function decline has an impact on later outcomes on dialysis,
definitely.
Right? Are there other factors during the transplant period? I mean, you mentioned prevention of sepsis, but...
It's very recent data. I've not seen any analyses based on those trajectories that relate to sepsis. But one would predict that some of the patterns are occurring through overwhelming sepsis, through rejection episodes. I mean, the computer is telling us about bilinear decreasing, but bilinear decreasing looks like a stable graft with a septic episode or a stable graft with somebody who had a cardiovascular event. I mean, there's going to be confounding in there. But I think it's well worth us looking at those things, and I think there are meaningful differences between these groups. The rapidity of decline doesn't predict the outcome alone. It's the pattern that occurs with that decline. So you have a stable and then a rapidly decreasing group. The change in GFR over a period of time will be equal to a progressive decreasing group, but the outcomes may be different. I think it's very important.
The entire trajectory.
I think having a footprint over the transition period, not being a modality-based doctor, but being a doctor for your patient, carrying the journey through is the important thing in clinical care, but also in research.
Yeah, and there is statistical methods that can accomplish this analysis. As I learned recently from our statistical colleagues, like functional analysis that look rather at entire curves,
yes,
and just individual data points and so.
You talk from a very interested place, which is obviously a Mondo set, which is about a prospective data set of dialysis patients. But the power of joining with the STR or joining with another transplant data set longitudinally and joining those lines together would be immense, I think.
Can you comment on the risk-benefit ratio of treating late T-cell mediated rejection with depleting antibodies and long-term outcomes after graft failure?
I think that's a really great question. I don't know where that might have come from, but I think that the continued use of even low-dose steroid is important. The overly ambitious use of depleting antibodies or bolus steroids has an effect in the long term. And I think this is another position where we need to be real and understand that we might not achieve our outcome. So often it's about cutting losses. So the answer to the question is that I don't know how that then affects subsequent dialysis and long-term survival, but I would suspect that it adversely does. And anecdotally, at one point in the 80s, the longest surviving transplant patients and patients overall with renal replacement therapy was in Northern Ireland. And that was under the care of somebody called McGowan, where basically she had three main things, which was to treat sepsis quickly and adequately, to de-escalate immune therapy, and then admit when you had defeat. And I think the issue is that you need to stand up and live to fight another day. And I think that's where that question's coming from. Yeah.
Okay, thank you. Thank you. Another question. In children, we don't stop the tacrolimus because on average, they need 3 transplants in 25 years. Can you speak on what is the best approach would be based on existing data or your data?
Yeah. So we're a center that does look at donor-specific antibodies, retransplantation, and rejection quite closely. What we locally do is opt for a low-dose tacrolimus regimen. Certainly, I think decrement and removal of steroids would be an advantage. And certainly, no tacrolimus is not a great option in regard to sensitization. So I completely agree with a young person who's a little bit older, and a young old person, right? I mean, it's the same group. So I think that certainly your approach is a reasonable one. We don't know the effects on residual renal function. I think that's one of the things that everybody's fearful of, but it's unmeasured, and I think it needs to be.
But sepsis was a significant death factor, right? So
yep. Sepsis with steroids, not with CNIs.
okay.
So I think that you're probably on fairly safe ground in as much as we know. My talk was comprehensive but not exhaustive of the literature, but I think that those were the main papers.
Okay, any additional questions? If not, then really thank you, Neill.
Thank you,
again.
thanks very much.